with you the RCOG Guideline, Placenta Praevia and Placenta Accreta Diagnosis and Management, and this guideline was published in September 2018. Okay, so now let us discuss very important features of this guideline. Okay, the first and very important thing in this guideline is that of the antenatal diagnosis and care of women with placenta previa or low-lying placenta. Okay, now it's written in this guideline that what risk factor for women with placenta previa or low-lying placenta. Okay, the risk factors are basically two. First of all, cesarean section, and secondly, ART. Okay, cesarean delivery is associated with increased risk of placenta previa in subsequent pregnancy, and this risk rises as the number of previous cesarean section increases, and assisted reproductive technology and maternal smoking increase the risk of placenta previa. So, cesarean section, ART, and maternal smoking. Now another question arises, should we screen women for placenta previa or low-lying placenta? If so, at what gestation, with what follow-up? The answer is that we have to do the mid-pregnancy routine fetal anomaly scan. Okay, that anomaly scan will show us about placenta localization. Okay, that anomaly scan should include placenta localization, thereby identifying the woman at the risk of persisting placenta previa or low-lying placenta previa. Okay, now there is difference between placenta previa and low-lying. Okay, it's written. Okay, the definition is written here that the term placenta previa should be used when placenta lies directly over the internal os. Okay, and for pregnancies more than 16 weeks of gestation, the term low-lying placenta should be used when placental edge is less than 20 mm from internal os on transabdominal or transvaginal scanning. Now, if we find either low-lying placenta or placenta previa on routine anomaly scan, what we have to do? We have to do scan at 32 weeks of gestation. Okay, so it's written that if placenta is thought to be low-lying, less than 20 mm from internal os, or previa covering the os at routine fetal anomaly scan, follow-up ultrasound examination including TBS is recommended at 32 weeks of gestation to diagnose persistent low-lying placenta or placenta previa. Now here it's written that what is the role and what are the risks of TBS. Okay, it's written that clinicians should be aware that TBS for diagnosis of placenta previa or low-lying placenta is superior to transabdominal and transperineal approaches and is safe. Okay, so TBS is considered safe and very much diagnostic. Okay, so what we have to do if we find low-lying placenta at 32 weeks? If a patient with persistent low-lying placenta or placenta previa at 32 weeks of gestation who remain asymptomatic, an additional TBS is recommended at around 36 weeks of gestation to inform discussion about the mode of delivery. Okay, and another thing is that we have to do cervical measurement. Okay, that may help facilitate the management decision in asymptomatic women with placenta previa. Okay, and a short cervical length or TBS before 32 weeks of gestation increases the risk of preterm emergency delivery and massive hemorrhage at cesarean section. Okay, now coming to the point that where should the woman with the low-lying placenta or placenta previa be cared for in the third trimester? Okay, it's written that and a woman with a recurrent period bleeding or low-lying placenta or placenta previa. So where should we do care of these women? Okay, it's written in the middle part of the that appendix 2. Okay, the first was those were of asymptomatic women. So in the middle we had patients with a recurrent period bleeding. So what we have to do in those cases, we have to tailor antenatal care, including hospitalization to individual woman's need and social circumstances, that is distance between home and hospital and availability of transportation, previous bleeding episode, hematology laboratory results, and acceptance of receiving donor blood or blood products. Now, if we admit the patient to the hospital where hospital admission is decided, then we have to do risk assessment for venous thromboembolism according to the RCOG guideline for thromboprophylaxis 37A. Okay, and this need to balance the risk of developing venous thromboembolism against the risk of bleeding from placenta previa. Okay, we have to balance the risk and then decide whether she needs prophylaxis or not. And it's also important that the women who are treated in home in third trimester, okay, we should advise her that she should attend hospital immediately if she experiences any bleeding, including spotting, contraction, or pain, okay, including weight, suprapubic period like aches. Okay, so how would we do counseling of the asymptomatic patients with the low-lying placenta or placenta previa? Okay, we have to tell them women with asymptomatic previa or low-lying placenta in the third trimester should be counseled about the risk. About the risk of what? Risk of preterm delivery and obstetric hemorrhage. Okay, these two things are very important. And the care should be tailored to the individual needs. Along with that, women with the asymptomatic placenta previa confirmed at 32 weeks follow-up scan and managed at home should be encouraged to ensure that they have safety precautions in place, including having someone available to help them as necessary and ready access to the hospital. Now, is there any place, any role of cervical cerclage in women with placenta previa or low-lying placenta? Okay, the answer is that the use of cervical cerclage to reduce bleeding and prolong pregnancy is not supported by sufficient evidence to recommend its use outside the clinical trial. So we don't have to consider cervical cerclage in every patient with placenta previa or low-lying placenta. Now, the role of corticosteroid. Okay, at what circumstances and at what gestation should women be offered antenatal corticosteroid? Okay, it has great role, and it's written that a single course of antenatal corticosteroid is recommended between 34 to 35 plus 6 weeks of gestation for women with low-lying placenta or placenta previa. Okay, and is appropriate prior to 34 weeks of gestation in a woman at higher risk of preterm birth. Okay, so those at higher risk, they should have corticosteroid prior to 34 weeks. Now, is there any place for tocolysis in women presenting with symptomatic low-lying or placenta previa who are in suspected preterm birth? Yes, it has a little bit role. Okay, the role is that tocolysis for a woman presenting with symptomatic placenta previa or low-lying placenta may be considered for 48 hours just to facilitate administration of antenatal corticosteroids. Otherwise, it's very important to know that if delivery is indicated based on maternal or fetal concern, then tocolysis should not be used in an attempt to prolong gestation. Now, at what gestation should planned delivery occur? It's written that if patient is symptomatic, like in that case is late preterm 34 to 36 plus 6 weeks of gestation, delivery should be considered. Okay, for those women with placenta previa or low-lying placenta and history of vaginal bleeding or other associated risk factor for preterm delivery. Okay, and the delivery timing should be tailored according to antenatal symptoms. And for women presenting with uncomplicated placenta previa, delivery should be considered between 36 and 37 weeks of gestation. Now, sometimes the question arises that can we offer vaginal delivery to these patients, and in what situation is vaginal delivery appropriate for women with placenta previa? Okay, it's written that in women with third trimester, asymptomatic low-lying placenta, the mode of delivery should be based on the different things. First of all, the clinical ground. Secondly, the woman preferences, and supplemented by ultrasound finding, including the distance between placental edge and fetal head position relative to the leading edge of placenta on TVS. Okay, so first of all, clinical ground. Secondly, woman preferences. Third, ultrasound findings. Now, optimizing the delivery of women with placenta previa, this is very important, and it's written that prior to the delivery, all women with placenta previa and their partners should have discussion regarding the delivery. Okay, and the indications for blood transfusion and hysterectomy should be reviewed, and any plan to decline blood or blood products should be discussed openly and documented. Placenta previa and low-lying placenta carry risk of massive hemorrhage and hysterectomy, and delivery should be arranged in maternity unit with on-site blood transfusion services and access to the critical care. Now, there are certain high-risk group in this regard. First of all, those with atypical antibodies, and secondly, those with anemia. Okay, so women with atypical antibodies form particularly high-risk group, and the care of these women should involve discussion with a local hematologist and blood banks. Prevention and treatment of anemia during antenatal period is recommended for a woman with placenta previa or low-lying placenta as for any pregnancy. Now coming to the delivery of the woman with placenta previa or low-lying placenta, what grade of obstetrician and anesthetist should be involved in the care of these women? About this, it's written that it's the minimum requirement for planned cesarean section for the woman with placenta previa. The surgical procedure should be carried out by an experienced operator. Okay, so this is the minimum requirement. Maximum requirement is even greater than this. Okay, and in case of planned cesarean section for previa or low-lying placenta, senior obstetrician and senior anesthetist should be present. These two consultants should be present at the delivery, within the delivery or theatre suite where the surgery is occurring. And when emergency arises, these two people should be alerted immediately and attend urgently. Now, what type of anesthesia is appropriate for these women? It's written that the regional anesthesia is considered safe because the risk of hemorrhage are lower in this as compared to those with a GA. But the woman with anterior placenta previa or low-lying placenta should be advised that it may be necessary that we can convert regional anesthesia into GA if required. Now, what blood products should be available? It's written that we should have close liaison with hospital's transfusion laboratory. There should be rapid infusion and fluid warming devices. Now, there are certain groups of women who decline blood products. Okay, it's written that cell salvage is recommended for a woman where anticipated blood loss is great enough to induce anemia, in particular women who decline blood products. Now, what surgical approaches are appropriate? It's written that if the fetus is transverse, then we have to consider vertical skin or uterine incision in order to avoid placenta, particularly below 28 weeks of gestation. Now, there is a role of ultrasound as well. Pre-operative and intraoperative ultrasonography has a very important role to precisely determine placental localization and optimal place for uterine incision. Now, sometimes placenta is transected during the uterine incision. So what we have to do in that case, we have to do immediately clamping of the umbilical cord after fetal delivery to avoid excessive fetal blood loss. Now, what we have to do in case of PPH? First of all, pharmacological measurement. If those fail, we have to go for intrauterine balloon tamponade and then surgical hemostatic technique as soon as possible. And interventional radiological techniques should also be urgently employed where possible. And if conservative and medical surgical methods prove to be ineffective, then we have to go for hysterectomy as soon as possible. Now, coming to the placenta accreta spectrum, okay, antenatal diagnosis and outcome of women with placenta accreta spectrum. What are the risk factors for women with placenta accreta spectrum? Well, the major risk factors for placenta accreta spectrum are history of accreta in previous pregnancy, first of all. Secondly, previous cesarean delivery and other uterine surgery, including repeated endometrial curettage. Okay, and this risk rises as the number of prior cesarean section increase. Okay, sometimes the woman requests elective cesarean section for non-medical indications. Okay, and about this, it's written that these women should be informed of the risk of placenta accreta spectrum and its consequences for the subsequent pregnancies. Now, how can placenta accreta spectrum be suspected and diagnosed antenatally? About this, it's written that antenatal diagnosis of placenta accreta spectrum is crucial in planning its management and has been shown to reduce maternal morbidity and mortality. And how we suspect this case: previous cesarean delivery and the presence of anterior low-lying placenta or placenta previa. These things should alert the antenatal care team of high risk of placenta accreta spectrum. Now, ultrasound screening and diagnosis of placenta accreta spectrum. It's written that ultrasound imaging is highly accurate when performed by skilled operator with experience in diagnosing placenta accreta spectrum. And we have to refer women with any ultrasound features suggestive of placenta accreta spectrum to the specialist unit with imaging expertise. And you can see from Appendix 2 that the woman with a history of previous cesarean section or have anterior low-lying placenta or a placenta previa at the routine fetal anomaly scan, these should be specifically screened for placenta accreta spectrum. Now, what is the role of the MRI in diagnosis of the placenta accreta spectrum? It's written that the clinician should be aware that the diagnostic value of MRI and ultrasound imaging in placenta accreta spectrum are similar when performed by the expert. But some advantage of the MRI is that it may be used to complement ultrasound imaging to assess the depth and invasion and the lateral extension of the myometrial vein, especially with the posterior placentation or in the woman with ultrasound signs suggestive of parametrial invasion. In these things, MRI may have role. Now, where should women with placenta accreta spectrum be cared for? It's written that the woman diagnosed with placenta accreta spectrum should be cared for by multidisciplinary team in a specialist center with expertise in diagnosing and managing placenta invasion. Okay, and delivery for the woman diagnosed with placenta accreta spectrum should take place in the specialist center with logistic support for immediate access to the blood transfusion. Okay, adult intensive care and neonatology care unit by multidisciplinary team with expertise in complex pelvic surgery. Now, when should delivery be planned for women with placenta accreta spectrum? If written that in the absence of risk factor for preterm delivery in women with placenta accreta spectrum, we have to plan delivery between 35 to 36 weeks of gestation. Okay, because that provide the best balance between the fetal maturity and the risk of unscheduled delivery. Now, something about planning delivery of women with a suspected placenta accreta spectrum. It's written that once the diagnosis of placenta accreta spectrum is made, okay, and a contingency plan of emergency delivery should be developed in partnership with the woman, including the use of institutional protocol for the management of maternal hemorrhage. Now, what should be included in the consent form? I would discuss briefly that these women should have clear discussion regarding the risk, like the risk of massive obstetric hemorrhage, risk of urinary tract damage, the risk of blood transfusion, the risk of hysterectomy. Okay, and we have to tell her about the possible need of intervention in case of the massive hemorrhage, including the cell salvage and interventional radiology. What health professionals should be involved? The thing is the same, that multidisciplinary team approach, including senior anesthetist, obstetrician, gynecologist with appropriate experience in managing the condition and other surgical specialties if indicated, and in emergency, the most senior clinician should be available. Okay, what anesthetist is the most appropriate? It's written that the choice of anesthetic technique should be made by anesthetist, okay, conducting the procedure. But at the same time, it's written that the woman should be informed that during procedure, it may be possible to convert regional anesthesia into general anesthesia. Now, what surgical approaches should be used for a woman placenta accreta spectrum? Okay, first of all, cesarean hysterectomy. Okay, and rather than attempting to separate the placenta from uterine wall, it's better to leave the placenta in situ. Now, in what cases we have to go for the uterus preserving surgery? Okay, it's written that when the extent of placenta accreta is limited in depth and surface area, and the entire placental implantation area are accessible and visualized, then the uterus preserving surgery may be appropriate, including the partial myometrial resection. But it's written that the uterus preserving surgical technique should only be attempted if there is appropriate expertise to manage such situation, and there is appropriate counseling with the patient regarding the risk and with the informed consent. And about ureteric stents, it's written that there is currently insufficient data to recommend its use, but we can use it when the urinary bladder is invaded by placental tissues. Okay, and what surgical approach should be used for women with placenta accreta? In these women, we can't go for the uterus preserving surgeries, and there is limited evidence to support uterus preserving surgery. Okay, and the woman should be informed of the high risk of peripartum and secondary complications, including the need for secondary hysterectomy. Now, coming to the expectant management, this is very important that sometimes we leave the placenta in situ. Okay, because it's written that elective peripartum hysterectomy may be unacceptable to the woman desiring uterine preservation or considered inappropriate by surgical team. In such case, leaving placenta in situ should be considered. But when we do like this, there should be local arrangement to ensure regular review of the patient, ultrasound examination, and access to emergency care. in case of complications like bleeding or infection. Now, methotrexate adjuvant therapy is of unproven benefit and has significant adverse effects, so it should not be attempted. Now, when does the role of interventional radiology comes? Okay, in that it's written that the large studies are indicated, large studies are necessary to determine the safety and efficacy of interventional radiologist. Okay, but it's also written that women diagnosed with placenta accreta spectrum who decline blood transfusion should be cared for in a unit with an interventional radiology service, means they can get benefit. Now, how can these women with diagnosed or unsuspected placenta accreta spectrum be best managed at delivery? Okay, so in case of undiagnosed and unsuspected case, we have to follow a specific approach. Okay, about this it's written that if at the time of elective repeat C-section, we are doing it in the common centers, and where both mother and babies are usually stable, but it is immediately apparent that placenta accreta is present on opening the abdomen. Okay, or we have opened the abdomen, we find that there is placenta accreta. Okay, so what we have to do, the cesarean section should be delayed until appropriate staff and resources have been assembled and adequate blood products are available. So we shouldn't go for cesarean section as soon as possible. Cesarean section can be delayed a little bit if in case the mother and the baby are stable. Okay, and this involves the closure of the maternal abdomen and urgent transfer to specialist unit for delivery. Okay, and in case of unsuspected placenta accreta spectrum diagnosed after the birth of the baby, the placenta should be left in situ and emergency hysterectomy performed. We shouldn't attempt to separate the placenta. Okay, thank you so much. This is all about this guideline. Thanks a lot for your patience. Allah Hafiz.